Thank you, Vinay, for accepting my proposal for speaking on this platform. Our moderator is Dr. Nandita Prabhat, and our chairpersons are Dr. Bimal Paliwal, Professor Bimal Paliwal from SGPGI Lucknow, and Professor Deepak Goyal from Himalaya Institute of Medical Science, Dehradun. So I welcome you all on this evening, and topic is migraine. So I hand over the platform to Nandita for further
Thank you,
proceeding.
sir. Thank you, sir. A very good evening to all of you. So today we have gathered here on this platform for a virtual CME on the topic migraine and overview and recent updates. It's really a great honor and privilege to welcome you all. During the last few years, multiple newer migraine therapies have emerged with a growing interest in this field. I'm sure today's talk will give us some newer insights in migraine management. I would now like to welcome our esteemed speaker and chairpersons for today's session. It's my pleasure to introduce today's speaker, Dr. Vinay Agarwal, sir. He is a renowned consultant neurophysician at Agra with a work experience of more than 15 years. He has done his DM neurology from SMS Medical College, Jaipur. He has various publications in national and international journals. To chair this session, I would like to welcome our chairpersons, Dr. Vimal Paliwal, sir, who is currently Professor, Department of Neurology at SGPGI Lucknow. He has a work experience of more than 20 years with multiple academic excellence awards, research projects, and many international and national publications. The next chairperson is Dr. Deepak Goyal, sir. He has done his DM Neurology from SGPGI Lucknow. He is currently working as Professor and Head of Neurology at Himalayan Institute of Medical Sciences, Dehradun. It's an honor to welcome such doyens of neurology at this platform. I now hand over the mic to our chairpersons for today's session. Thank you.
Technical team, please mute everyone as except the speakers. Technical team, please mute everyone other than speakers.
Deepak sir.
Deepak sir, please.
Hadi. We are on.
Technical team, please mute everyone else other than speakers.
I think we should just start the lecture directly because it is already we have introduced everyone and we know each and every person. So I thank you all for being the part of this important CME, and it is a very good initiation by Dr. Arvind. So I think we should not waste the time. Straight away we can go for the lecture. Thank you very much.
Okay, should I share the screen, Arvind?
Yes.
Are my slides visible?
Yes.
On a full screen now?
Yes.
And am I audible now clearly?
Yes, you're audible.
Okay, thank you. Thank you, Dr. Arvind, for giving me the opportunity to discuss this very important topic and an ever-growing topic, and is of paramount clinical importance. So today's topic is migraine and overview and recent update. So migraine is a primary headache in which headache and associated features are without any exogenous cause, that is without any infection, tumor, or any structural cause. So it is a primary headache. It is the second most common headache after tension type headache, but most common neurological cause of disability, because most of the tension type headache patients don't concern as the migraine patient concern. So they are more likely to concern or come to a neurologist than a more common tension type headache. 19% of women and 10% of men have migraine. So primary headaches like tension type, migraine, and cluster, these are three common type of headaches, out of which tension type is the most common type. Now, to confuse or the matter, clinical features of migraine may overlap with secondary causes of headache. That is, sometimes the secondary cause like tumor may activate the migraine circuit in the brain, and then the phenotypic feature of headache may be same as that of migraine, even in a secondary cause of headache. And patients with secondary headaches may have long history of primary headache in their young adulthood or childhood. So we cannot rely entirely on the phenotype of headache or the clinical features. There are certain red flag signs which we should always be alert of to rule out secondary headaches. If a patient of headaches comes to us, first is like systemic symptoms. If patient is having weight loss, fever, so we should always think in terms of infectious disease. Then secondary disease, like if patient is having tuberculosis or malignancy, we should always try to rule out the structural cause of headache. Similarly, neurological symptoms and signs like papilledema or cranial palsy or hemiparesis we should always look for secondary headache. Thunderclap headache, it is very important to ask for the onset of headache, especially if it is a recent headache. Thunderclap headache starts immediately and peaks within 1 minute, because thunderclap headache may have other features similar to that of migraine, except the rapidity of onset. So if we don't ask about it, we can miss diagnosis like subarachnoid hemorrhage. Older age of onset, look for temporal arteritis. Then positional pregnancy or postpartum like CBT, or the headache precipitated by Valsalva, like which also indicates some intracranial cause of headache. So we should always pay attention to red flag signs before labeling headache as primary headache. And so there are certain diagnostic criteria for migraine. There are diagnostic criteria for migraine without aura. Most important, which I feel apart from the clinical feature, is the number of attacks. At least 5 attacks should be there, because sometimes the headaches like subarachnoid hemorrhage or vasoconstriction headache, these can have clinical features similar to migraine, but when we inquire the frequency, there may be only 1 or 2 episodes. So at least 5 attacks should be there, fulfilling the below criteria. That is headache lasting for 4 to 72 hours, unilateral location, throbbing or pulsating quality, moderate or severe intensity, and aggravation by routine physical activity. Associated features should be like nausea, vomiting, photophobia, or phonophobia. So these are the criteria by which we can make the diagnosis of migraine without aura. In my opinion, attack frequency is very important to note. Similarly, there are criteria for migraine with aura, in which at least 2 attacks should be there with aura, fulfilling criteria B and C. That is 1 or more fully reversible aura symptoms. The most common being visual, then sensory, then speech, language, and very rare motor, brainstem, and retinal symptoms can be there. And this should all be reversible. And at least 3 of following 6 criteria, that is the aura should develop gradually, which we'll discuss later, why it is important about the duration of symptom. 2 or more aura symptoms occurring in succession, like patient is started having visual aura, then he starts having sensory aura. Each aura symptom lasts 5 to 60 minutes, and at least 1 aura symptom is unilateral and positive. And this aura is accompanied or followed within 60 minutes by headache. So these are the criteria for migraine with aura. Now there is a term called chronic migraine, which is defined by the presence of headache on more than 15 days per month for more than 3 months. So what is the risk of developing chronic migraine? The most important modifiable risk being inadequate acute treatment of migraine attacks. That is, if we don't treat acute attack of migraine attacks, then there are high chances that patient will develop chronic migraine. Similarly, not using prophylactic treatment judicially. That is, if prophylactic treatment is indicated and we are not using it, then also there are chances that patient will end up into chronic migraine. These apart from these modifiable factors, there are certain non-modifiable factors also, like female sex, head injury, low socioeconomic status, associated psychiatric or psychological symptoms. Medication overuse headache, it is also a subtype of this chronic daily headache, in which headache lasts for more than 15 days per month. Regular overuse of 3 months of drugs for acute treatment of migraine. The important point being which drugs are more prone to cause medication overuse headache. The most notorious drug being opioids, followed by aspirin, acetaminophen with caffeine combination, followed by triptans, and very low risk for non-steroidal anti-inflammatory drugs. So the opioids have the highest risk of causing medication of overuse headache if we use opioids very frequently. Phases of migraine, we all know phases of migraine like aura, headache, and postdromal phase. But recently, two more phases have been described, like premonitory phase, which precedes 48 hours prior to headache onset. It is important. It is a very non-specific features like fatigue, impaired concentration, and neck stiffness, and other psychological features may be there. But it is important to identify this so that we can stop the headache there only if we identify these premonitory symptoms. Premonitory symptoms can be identified by maintaining migraine diary. Migraine aura, it is a neurological symptom. That is a migraine symptom secondary to focal brain dysfunction that lasts for 5 to 60 minutes, and it occurs before or accompanies the headache. It is seen only in 1/3 of migraine, and sometimes this aura is not followed by headache, which is called as acephalgic migraine. It is very important that although it is very rare, but important to know about this acephalgic migraine, because the patient can come only with aura, then we have to differentiate it from either seizure or a vascular like transient ischemic attacks. So we should always keep in mind this diagnosis. Now, how to differentiate between aura versus vascular event, that is stroke. Aura usually precedes or accompanies headache, as we all know. Speed of symptom is very important. As we were saying during the criteria which has been defined for migraine, very fast onset for vascular, less than 1 minute. And for seizure, it is bit slower, but aura, it develops over 50 to 60 minutes. So it is quite slower. Second important being crossing vascular boundaries. This TIA usually follows vascular boundary, either middle cerebral artery or posterior circulation, but this migrainous aura will cross these boundaries and can have visual, then sensory, then motor symptoms. Sequential appearance of aura symptom favors aura, and stereotyped and often recurrent is seen in aura. Headache. Headache is usually unilateral, throbbing, and aggravated by physical activity or head movement. Can change sides during or between attacks. Important to differentiate from cluster headache. Range of headaches is 4 to 72 hours in adults and 2 to 48 hours in children, and can involve any part of head. It can also involve the neck as well as the sinus region. Important to know because often migraine headache is confused with either cervicogenic pain or sinusitis pain. So we should always know that this migrainous headache can involve sinus region as well as neck region. Now, post-normal phase also have non-specific symptoms. So how to assess the disability of patient's disability or to response to treatment, which can be done by maintaining certain score like migraine disability assessment score or maintaining migraine diary. It is very helpful to know the response to treatment. And we can also identify the triggers. We can also identify which drugs are helpful. So it is very important to note this. Common triggers. Triggers are very individualistic. We cannot generalize it. So each patient has to identify its own triggers, which is helped by maintaining migraine diary. If triggers can be related to diet, hormonal changes, environmental factors, or stress or anxiety related. Now, in brief, about certain migraine variants. First is basilar migraine. This is migraine with basilar or brainstem features like vertigo, ataxia, sensory symptom, or diplopia. And headache is usually occipital. It is usually seen in pediatric population, and as the child grows, this is replaced by common migraine. In older population, we need to differentiate it from vertebrobasilar insufficiency. Similarly, ophthalmoplegic migraine, it is also very common in children. And here we have orbital or retroorbital headache followed by ophthalmoplegia. And ophthalmoplegia may last from days to weeks and needs to differentiate from structural cause involving cavernous sinus or vascular abnormalities. So imaging is always indicated. But this can be identified by repeated symptoms and normal interictal period or intermigraine period. Sometimes, but this aura may not be that benign, and hemiplegia and persistent visual deficit may persist. Similarly, hormones have effect on migraine. In prepubertal period, the incidence of migraine is same in males and females, but it becomes more common after menarche. And there are certain migraine which can occur either exclusively during menses, that is true menstrual migraine, or can increase during menses. And while using oral contraceptive pills, we should always ask the history about migraine with aura, because if we are using only synthetic estrogen, then there is increased chance of ischemic stroke. Similarly, migraine frequency decreases in pregnancy in 70%. Pediatric migraine, there are certain variants like cyclic vomiting, abdominal migraine, vertigo. In all these variants, these are identified by stereotype symptoms, intermittency of symptoms, child remains all right between the symptoms, and we need to rule out the local cause. Like in cyclic vomiting, abdominal migraine, we have to rule gastrointestinal cause, and in torticollis and vertigo, we have to rule out posterior foci structural cause. Now, this is one slide about pathophysiology of migraine. It is very important because as we will discuss newer treatments, we should know where the treatment is targeted. Initial theory of vascular theory of, that is the vasodilatation for throbbing headache and vasoconstriction for aura, is no longer supported. Now, the migraine is considered to be a disturbance of a sensory system involving this trigeminal cervical complex, which receives input from trigeminal ganglion, cervical ganglion, and it relays to thalamus and to cortex. So, and it receives input from hypothalamus, locus coeruleus, and periaqueductal gray matter. So, the hypersensitivity of this sensory system is responsible, and this hypersensitivity is usually hereditary. But what exactly triggers this hypersensitivity is still not known. So, important is the vascular theory is no longer supported, and the circuit is considered to be involved in causation of migraine. And there are various mediators, the neurotransmitters involved, like CGRP, like pituitary adenylate cyclase activating polypeptide, serotonin, dopamine. These molecular mediators are the target for our treatment, and newer treatments are developed against these mediators. Role of imaging, important whenever there is doubt about secondary headache, which we have discussed. Usually CT to be avoided in children. Contrast MRI is the investigation of choice, and sometimes non-specific white matter hyperintensities can be seen. And whenever there are atypical features of migraine, like hemiplegic migraine, basilar migraine, or retinal migraine, we should always go for imaging. And last but not the least, on patients and family request, we have to get an imaging done, because as we have discussed initially, sometimes only on phenotypic basis, it is difficult to differentiate between primary and secondary headache. And it provides sometimes great relief to the patient that his or her scan is normal. Now we come to management. After we have discussed the clinical feature and pathophysiology, patient education, I think, is the most important, since this disease cannot be eradicated. So patients should know that it is an inherited disorder. It can be modified by lifestyle adjustment and medications, and it's still not life-threatening. So we should always reassure about these points to the patient. Management can be divided into either acute treatment of acute headache, or prevention of the attacks, or preemptive treatment. Preemptive treatment means when we know exactly what is the trigger of migraine, and migraine occurs only during that period. The classical example means true menstrual migraine, in which we can provide analgesics during menses and can prevent the migraine attacks. In all other cases, we have to give preventive treatment on all days. So we all know the principles of treatment that modify identifiable triggers, treat comorbid mood and anxiety. It is very important. And appropriate use of pain relief medications to prevent medication overuse in headache, maintenance of headache diary, and preventive medicines whenever required. So treatment is individualized and it cannot be standardized. Non-pharmacological treatment like rest in dark place, proper hydration, and if stress is an issue, try to manage it. Pharmacological treatment for acute attack of migraine. First is non-specific analgesics. And if for mild headaches, this is usually sufficient. Acetaminophen, NSAIDs like aspirin, ibuprofen, and naproxen. Although naproxen is the most favored drug, but studies show that ibuprofen is as effective, in fact, more effective than migraine in few studies. And other antiemetic like promethazine, prochlorperazine, promethazine, and metoclopramide can be used if patient is not able to take oral medicines. Opioids and barbiturates should always be avoided because of high addiction potential, and it does not treat the underlying headache mechanism. So in patients who have contraindications to all other treatment, like patients having severe asthma or COPD, associated cardiological issues, so very small subset of patient where it can be used. Otherwise, it should be avoided. This we have already discussed, like aspirin, ibuprofen, naproxen, diclofenac, potassium. Now we come to migraine-specific acute treatment. Here we have triptans, we all know about them, ergots, which are not much used, and newer treatment like ditans and gepants, which are the emerging treatment. Triptans are 5-HT, 1B and D agonist. There are 7 triptans available, like sumatriptan, almotriptan, alitriptan, and so on. But they are contraindicated in vascular abnormalities, like if patient is having a stroke or he is having cardiac disease. Similarly, they are contraindicated in hemiplegic as well as basilar migraine. Non-specific side effects are very common, like tingling, flushing, feeling of fullness in head, neck, or chest. Serotonin syndrome, if it is used with other serotonergic drugs, have been mentioned, but recent studies have shown that serotonin syndrome is not more common when this SSRI or SNRI are used alone. So it is not found in clinical, this serotonin syndrome. This fear is not found in clinical studies. In which sumatriptan is available in subcutaneous, intranasal, as well as oral. Zolmitriptan is available as intranasal, and all other triptans are available as oral only. We need to use subcutaneous and intranasal whenever patient is not able to take the oral medicines because of severe nausea, vomiting. So how to choose the right triptan? If the patient's headache is very fast and it is not of prolonged duration, then sumatriptan is the choice of triptan. If it is bit slower and moderate pain, moderate onset, then rizatriptan or elmotriptan, alitriptan is helpful. Now, if the headache is slow onset and long acting, that is patient is having headache for almost 48, 72 hours, and we know that it is going to be long duration, then forwardtriptan and naratriptan is helpful. So by this, by maintaining headache diary or patient's past history, we can choose the appropriate triptan. Now, the combination of sumatriptan and NSAIDs, like the triptan and NSAID is better than alone. The patients who are not controlled either alone on NSAIDs or they are not controlled on triptan, the combination is better. Their effect is synergistic because the triptans have vascular, neurogenic, and central action, and this NSAIDs have vascular neurogenic action. If we add both, so we'll have a better results or synergistic effect as compared to when we are using alone either triptans or NSAIDs. This sumatriptan and naproxen combination is very popular and easily available. Ergots, these are non-oral, expensive, difficult to get. There are also non-selective 5-HT1B D agonist. They are also contraindicated in vascular comorbidities but they are useful in whom triptans are not effective. So both these ergots as well as triptans, we are not able to use in vascular comorbidity patients, which form a large subgroup of patients. So we require a drug which is either as effective or better than triptan, but we can use it in patients with vascular comorbidities like CD or stroke. So the ditans, or in which lesmeditan, this is the drug which is a 5-HT1F agonist. It does not have 5-HT1B effect, so it is more selective and it does not have vasoconstricting effect, so it is safe in CAD and stroke. And it has become available also. So it is effective for acute treatment of migraine, useful in those on which triptans are ineffective or contraindicated. Side effects are dizziness, fatigue, paresthesia, and sedation. This is very important to know that this lesmeditan causes sedation as well as dizziness. So it has to be used only during night time. Once daily dosing, dose is 50, 100 to 200 milligram. Absorption is not affected by food. No dose adjustment is required in mild to moderate renal liver dysfunction. In advanced renal or liver dysfunction, it cannot be used. Only once daily dosing can be given. And it is very important to tell patient that 8 hours he should wait, or he or she should wait before driving or operating machinery. It may cause serotonin syndrome, and it is not safe in pregnancy and pediatric population. So to summarize about lesmeditan, it is can be used in home in which triptans are ineffective or contraindicated. And most important side effect, we should know that it causes sedation. So should be given during night time only. Then other group of drugs which are effective in acute treatment of migraine are GPANTs. They call GPANTs, CGRP receptor antagonist, in which they are approved in 2019 and 20. Two drugs, ubrogepant and rimegepant, is popular. We can use ubrogepant if we know additional dose is required, because it can be its dose can be repeated. And rimegepant, it can be used only once. It is also safe in cardiovascular patients. So indications are again same on triptans are ineffective or contraindicated due to vascular comorbidities. Then there is new mode of treatment which is known as neuromodulation. It is useful in those patients on whom we cannot use pharmacological treatment because of contraindications, or because of medication overuse, or because the drugs are not effective, or the patient is not willing to take the medicines. These are external trigeminal stimulation, single pulse transcranial magnetic stimulation, non-invasive vagus nerve stimulation, or remote electrical neuromodulation. So these are the newer modalities or non-pharmacological treatment for acute attack of migraine, and they have found to be effective. But difficulty in analyzing their effect is that they cannot be compared with placebo, because all are in all these we have to give stimulation, and if we are giving placebo without stimulation, then it becomes very clear. So their trial is very difficult for this neuromodulation. So what are the parameters of efficacy of acute treatment? That first, it should work in majority of attacks. Pain should disappear in 2 hours, and patient should be able to function in 2 hours, and he should be returned to do daily activities after the treatment. So we have discussed till now about the clinical features, the criteria, the pathophysiology, the acute treatment, and and in acute we have the recent treatment. Now, what are the preventive medication? What are the indications of preventive treatment? First and foremost, we have discussed initially in this talk that to prevent the chronic migraine, judicial use of preventive medication is very important. So if the attacks are frequent, like 2 severe attacks or 4 less disabling attacks per month, acute migraine treatment is ineffective or contraindicated. Patient is having medication overuse headache, and There are certain variants of migraine in which, regardless of attack frequency, we have to use the preventive treatment to prevent complications like hemiplegic migraine, brainstem migraine, and frequent, prolonged, or uncomfortable aura symptoms. So, preventive treatment, they reduce the frequency, severity, and duration and disability, and improves the quality of life. It has been proved. It improves responsiveness to acute treatment also, and prevents disease progression. But there should be realistic expectations. We should inform patients before starting treatment that it is to the best possible. It is effective only in 50 to 75%, and mostly it is affecting in 50 to 60% only. And it takes 2 to 12 weeks before any drug is we can tell them that it is ineffective. So we should wait for 2 to 12 weeks. And every drug is not effective in every patient, so it is in trial and error basis. So if one drug fails, then patient should not feel disappointed. We should tell them at least we can shift to another drug, and there are many options available. So it is another very important question which patients usually ask: when to discontinue? So no definitive answer is there, but longer the better. If concerns about discontinuing, that if we are concerned about discontinuing that the headache will return, then for a longer period it should be used. And there are one trial done on propranolol where they have found that at least we should wait for 3 to 6 months after headache freedom. Then also slow taper should be done. That drugs should not be withdrawn immediately. Now, the drugs which are used for this prophylactic treatment, first highly effective drugs are divalproic sodium, topiramate, metoprolol, this is cardioselective beta blocker, propranolol non-selective beta blocker, flunarizine, botulinum toxin, and the new addition that is emerging treatment, CGRP, the monoclonal antibodies. Moderately effective drugs are this antidepressants, amitriptyline, and venlafaxine. But venlafaxine has very high significant withdrawal symptom. So if we even if it is still very effective, but it is used less often. Poor efficacy drugs are antihypertensives like candesartan, cyproheptadine used exclusively in pediatric population, lisinopril, gabapentin, and pregabalin. Although it is poor efficacy, but it is very effective in patients who is having associated features of fibromyalgia, neck pain, back pain. So it is very good drug for these patients. And also their side effect profile is very favorable. So despite having poor efficacy, they can always be used in combination, especially in patients who have features of fibromyalgia associated with migraine. Verapamil, usually effective in patients with aura. Duloxetine, it is sometimes favored over venlafaxine because of lower abuse potential as compared to venlafaxine, less withdrawal symptom. And levetiracetam has also been used now. So there are certain drugs with poor efficacy, but they can still be used in a special subset of patients like cyproheptadine and gabapentin. A few words about these drugs, common things like topiramate, it is a first-line drug. Most important side effect being cognitive slowing and word finding difficulty. Patient usually have this symptom is very common, word finding difficulty. Then it can cause weight loss. So this side effect can be of helpful in obese patients with migraine. They can precipitate glaucoma, and they are contraindicated in patients with renal calculi. And always start with a low dose. Gradually dose build up is to be done. Divalproic sodium is very effective, but again, side effect burden is very high. Weight gain, hair loss, menstrual irregularity, hepatotoxicity, thrombocytopenia. So practically, it is very difficult to give this drug to female patients until unless we have exhausted with all other options. Flunarizine, we are using for a very long time. Can cause sedation, precipitate depression, and can cause weight gain. Beta blocker, there are many beta blocker like from non-selective like propranolol to selective like nadolol, ethanol, metoprolol. These are very effective. But for all these drugs, there are certain therapeutic limitations which everyone should know before prescribing these drugs. And like if patient is having blood pressure is on lower side, then antihypertensives as well as beta blockers need to be avoided. In asthmatic patients, beta blockers can't be given. Epileptic patients, tricyclic antidepressant should be avoided. In obesity, valproate, flunarizine, and tricyclic should be avoided. And in depression, flunarizine and beta blocker should be avoided. And women with childbearing age, valproate should be avoided. And patients with glaucoma and renal stones, topiramate should be avoided. So again, despite having very efficacious drugs, highly effective drug like divalproate, topiramate, still we have this long list of therapeutic limitations. So still we need newer treatment, a better treatment, which can be given in these patients also. So for this, here comes the role of this CGRP monoclonal antibodies. We have seen during the pathophysiology that CGRP is an important neurotransmitter involved in the pain pathway causing migraine. So anything against it will help in prevention of migraine, even in acute treatment. So CGRP antibodies are effective for both episodic as well as chronic migraine. It is highly efficacious, 50 to 75%, low side effect profile, and convenient dosing. It is excellent for polypharmacy because it has minimal interaction with other prophylactic drugs. But still, and side effect profile is very good. Less than 5% patient discontinue. Constipation, it is an important side effect. Injection side reactions and nasopharyngitis are common side effect. It also doesn't have any cardiovascular side effect. It is useful in those patients on whom previous preventive treatment, in which we have given at least 6 weeks trial of 2 conventional preventive medicines. Then they are indicated and they can be given in addition to those drugs without replacing them if it doesn't have much of side effects with the previous drug. But these antibodies are very expensive and they are contraindicated in pregnancy and lactation. The common, these 4 drugs have been approved, like eptinezumab, erinumab, fremonizumab, and galactozumab. Out of which all are subcutaneous except eptinezumab, there are IV. All acts on like ligand and except erinumab, which acts on receptor. And their dosing is very convenient from monthly to 3 months. So because of convenient infrequent dosing from monthly to 3 monthly, their efficacy is very high. Their minimal interactions, they can be added to other drugs and their minimal side effects. So these can well be a game changer in the management of migraine, preventive treatment of migraine, these CGRP monoclonal antibodies. This we have discussed how to choose the preventive treatment. Step care. Try to use monotherapy. If it fails, then add second drug. And we should always try to add second drug with having synergistic effect on the treatment. And the side effect should not be additive. And always should start with a lower dose. Then there are certain non-pharmacological treatments which always helps because as we all see in our clinical practice, these migraine patients have lot of anxiety features and psychological issues. So lifestyle modification, yoga, meditation, nutrition supplements, physical treatments also help sometimes. They can be synergistic with pharmacological treatment when they are used appropriately. Recently, the supplements of magnesium, riboflavin, coenzyme Q10, melatonin, vitamin D, and herbs feverfew have also been approved for this preventive treatment of migraine. And this is especially helpful in patients with migraine patients with pregnancy, whom we have very little to offer right now. So with this, I summarize my today's presentation. So important points being, which we have discussed, that secondary headache should always be excluded before labeling this as a primary headache. Appropriate treatment, both acute as well as preventive, is required to for prevention of progression of migraine, landing into chronic migraine or medication overuse. Newer drugs like ditans, CGRP antagonist, and monoclonal antibodies are very these are very helpful and further prevention of migraine attacks as well as acute treatment. So with this, I conclude my today's presentation. I know a lot of things might still have been left because migraine is such a vast topic, and but it was still. I again thank Dr. Arvind for giving me this opportunity to discuss this very interesting and very common clinical topic. Thank you.
Thank you, Dr. Vinay, for nicely presented overview of headache and recent advances in management of headache. So first of all, I again welcome our new participant. I welcome Dr. Ravin Garg, sir. Thank you for joining, sir. I welcome Dr. Kshitij. Doctor, I think a lot of names are there. We have a lot of persons to join. I would like to thank Dr. P.K. Maurya, sir, Dr. Ravindra, sir, Dr. Deepak,
Thank you.
Dr. Deepak, and many more. I welcome you all for joining this webinar, making this a successful webinar. Dr. Vinay has nicely presented the overview of migraine. If I have only one question, Dr. Vinay, regarding the recent advances in these migraine, regarding this ditans, you have told that it should be given daily.
No, ditans need not to be given daily. Ditans can be given once daily only. Those cannot be repeated. I may be wrong in while presenting, but it can be given once daily. The dose cannot be repeated.
Okay, for how long it can be given? Because none of us has experience with ditans or Gepants or any other newer drugs.
Ditans has been recently introduced. I think
I think we recently got this medicine in market.
Yeah, 2-3 weeks
month
ago.
back.
2-3 weeks ago only, I think.
Yes.
Ditans, any medicine which you are using for acute treatment, we should try to use them as less as possible to prevent medication overusing headache. So if we need to require these acute medications more frequently, then we should shift the patient's preventive medicine treatment. We should again analyze them that some other drug is required. But we cannot use any acute treatment on a daily basis.
So it should be given as and when required.
As and when required. It is for acute treatment. It is similar to triptans, but with no cardiovascular side effects. And
only one thing is added benefit of this ditans. That is, it is cardio safe.
It is cardio safe. And it is found a little bit more.
Gepants are not available in India, I think.
I do. I have also not. Gepants and antibodies.
Antibodies are not available.
Yeah. They are not available. Here I have never. But
So,
on a theoretical basis, they also look very promising.
Yes. Definitely.
Profile.
So I would like our chairpersons to have comment on today's this presentation. Dr. Vimal Paliwal,
सर आप स्टार्ट करिए.
हाँ ठीक है. Thank you, Dr. Bimal. It was a nice presentation. आपने विनय जी आपने ना थोड़ा सा टाइम लेके भी 45 मिनट में कवर कर दिया पूरा टॉक और इतना वास्ट टॉपिक है जैसा आपने बताया तो सारी चीजें आपने कवर कर दी. इट वाज ए नाइस. मैं तुम्हारी प्रेजेंटेशन के एक पार्ट का जो स्टेटमेंट है ना वो मैं डॉक्टर विमल से कंफर्म करूंगा. डॉक्टर विमल टीएमएस यूज कर रहे हैं हेडेक माइग्रेन में. तुमने बताया कि प्लेसिबो का कंपैरिजन नहीं होता है इसमें. तो जहां तक हम लोग क्योंकि हम लोग ना इस पे टीडीसीएस पे काम कर रहे हैं तो इसमें मेरा ये था कि जो शैम स्टिमुलेशन होता है वो प्लेसिबो ही होता है.
डेफिनेटली सर.
हाँ तो वो स्टडी जितनी भी है वो शैम स्टिमुलेशन वर्सेस एक्टिव स्टिमुलेशन पे है. एंड अभी तो काफी अच्छा डेटा कलेक्ट हो गया. डॉक्टर विमल इसमें कुछ आप बोलोगे तो ठीक रहेगा.
हाँ सर आप ठीक कह रहे हैं. शैम स्टिमुलेशन है उसमें उसका एंगल चेंज करके स्टिमुलेट करते हैं एंड देन इट इज नॉट वेरी इफेक्टिव. टीएमएस की बात जहां तक है तो कंपैरिजन ट्रायल्स हैव बीन विद शैम स्टिमुलेशन but single arm studies have also been there. Even a single arm study is good enough if it is producing very good results.
डॉक्टर विनय, मैं आपको एक और बताऊं, हम लोग अभी न्यूरो मॉड्यूलेशन सोसाइटी ऑफ इंडिया डेवलप किए हैं, उसमें हम लोग सब मेंबर हैं, कुछ जो एक्टिव कर रहे हैं काम। और अभी हम लोगों के पास चैलेंज ये है कि जो आपने बताया ना कि हाइपर सेंसिटाइजेशन ऑफ द नर्वस सिस्टम, तो इसमें आरबीएम पाथवे जो है ना, तो पेरिएक्विडिक्टल पीएजी आरबीएम पाथवे जो है ना, उसको हम लोग न्यूरो मॉड्यूलेशन से टारगेट नहीं कर पा रहे, क्योंकि उसके लिए डीप कॉइल चाहिए। अभी हम लोग सुपरफिशियल कॉइल से M1 स्टिमुलेशन से वो नहीं कर पा रहे हैं। तो कुछ और स्टडीज या कुछ और पैटर्न जैसे थीटा बस्ट पैटर्न वगैरह इसमें आ रहे हैं, जो अभी न्यूरो मॉड्यूलेशन को और आगे लेके जाएंगे। तो मे बी दैट विल गिव मोर नॉन इन्वेजिव मेथड फॉर स्टिमुलेशन। तो दैट इज माय इनपुट नंबर 1। नंबर 2, आपने थोड़ा सा बताइए कि क्या ये स्टेटस माइग्रेनस लाइक टर्म अभी भी एग्जिस्ट करती है क्या?
हाँ, स्टेटस मैग्नम से सर हेडेक परसिस्ट कर रहा है 40 to 72। मैनेजमेंट के लिए सर एक कॉन्सेप्ट मेरे ख्याल से ठीक है, बिकॉज वी address other things also apart from this analgesics and triptans and all this, like hydration, electrolyte imbalance, and this even steroids have been helpful. Status magnus as a concept, I think keep in mind कि
Yes, yes,
मैनेज
yes, yes.
जाता है from analgesics to hydration and this all electrolytes and all these things, because इतने लंबे हेडेक से वोमिटिंग अगर है पेशेंट को, is not taking orally, so चीज प्रोलॉन्ग करा देती है। सो बस वही
बस
लंबा
बिल्कुल।
बता रहा था कि-
हाँ, नहीं नहीं, बिल्कुल नहीं, वो तो हम लोग ऐसा ना छोटे छोटे माइनर फाइंडर से डिस्कस करके कवर कर सकते हैं। एक मैं तीसरा इनपुट, लास्ट इनपुट है मेरा, मैं एक हाउस को ये इन्फॉर्मेशन भी देना चाहता हूँ। अभी हम लोग पिछले कुछ वर्षों से ना क्रॉनिक पेन बायोसाइको सोशल मॉडल पे काम कर रहे थे। सो जो 3P होते हैं ना इसमें, प्रेसिपिटेटिंग, परपिचुएटिंग एंड प्रीडिस्पोजिंग फैक्टर, तो उसमें हम लोगों ने अभी एक सिफेलिया में पेपर पब्लिश किया 2023 में, जिसमें हमने देखा है कि क्रॉनिक माइग्रेन जो है डेफिशिएंसी ऑफ फेरिटीन, तो ये फेरिटीन डेफिशिएंसी इज ए वेरी गुड फैक्टर। जो हम लोगों ने पाया है कि जो नॉन रेस्पॉन्डर होते हैं या परसिस्टेंट हेडेक के होते हैं, और स्पेशली इन फीमेल, तो लो ferritin is a very good factor, reversible, which can be reversed and we can have a good response to treatment. That is my comment only. Thank you very much.
Any other
ओझा
question
जी?
from the house? Sir, Vimal sir.
हाँ, मैं ये कह रहा था, इट इज वेरी नाइसली प्रेजेंटेड बिकॉज माइग्रेन इज सच अ वास्ट टॉपिक एंड डॉक्टर विनय हैज very comprehensively covered most of the aspects. We can open the house for questions. I think we have some more time.
सर अभी ये मोनोक्लोनल एंटीबॉडीज तो कहीं भी अवेलेबल है इंडिया में? नहीं अभी।
हाँ,
हाँ
अवेलेबल है,
है,
अवेलेबल है।
available.
हाँ, जो जो इरेनुमैब है वो सुवीरे के नाम से नोवार्टिस इंडिया में लाया, काफी यूज कर चुके हैं लोग बाग। हाँ, हम लोग ने भी यूज किया है, तो दैट इज अवेलेबल।
तो सर
I
एक्सपीरियंस।
have one query. Shall I?
या
हाँ
प्लीज
Yes.
प्लीज।
सर, ये जो मोनोक्लोनल एंटीबॉडीज हैं, जैसे हम लोग बोलते हैं 3 to 6 months का ड्यूरेशन होता है प्रिवेंटिव ट्रीटमेंट का, तो इनके लिए भी कुछ ड्यूरेशन डिफाइंड है क्या?
1 year है, 1 year।
Okay.
हाँ,
इफेक्ट कैसा है सर? आपने इस मतलब आर दे इफेक्टिव और व्हाट बेटर देन?
एक्चुअली
अभी तो हाँ, आप
इसका
बताओ।
जो जो हम लोगों का बहुत लिमिटेड एक्सपीरियंस है। माय एक्सपीरियंस माई
Yes.
सेल्फ इज अ वेरी स्मॉल ग्रुप ऑफ पेशेंट्स, बट व्हाट आई हैव सीन इज फ्रॉम माय कोलीग्स आल्सो एंड माय नो हाउ, जो डिस्टेंटली लोग भी दिए हैं उनका भी नॉलेज है, बिकॉज वी वर्क इन हेडेक, तो वो कंपनी वाले भी आके कुछ शेयर करते हैं इन्फॉर्मेशन। सो दे क्लेम दैट द रिस्पॉन्स इज वेरी गुड, अराउंड 40%,
बट
but our own experience is not very good with Suvire, because what happens in studies, they give treatment naive patients, but what they recommend is when the treatment with the prophylaxis other drugs fails, so they are really very resistant patients and don't respond that well to even these monoclonal antibodies. This is my experience. This is not a truth, may not be a universal truth, but this is how it is.
You sir, few persons said Botox is also using.
Sir, Botox, again,
But
this problem
Botox,
is same. Problem is same, that those who are really resistant to drugs, they won't respond to even Botox. But
yes.
problem is that migraine itself has got a very high placebo effect. So some patients might respond, but you won't know, because the response of even prophylaxis is short-lived.
Yes, sir.
So that has to be repeated. Like for even Botox, it has to be repeated for after 3 months. Placebo effect is again for 2 to 3 months. So it is sometimes very difficult to know whether it's a real effect or a placebo effect. But we have given Botox also, and there's a mixed response. Sometimes it is actually the selection bias also, because in institutes we get patients who are really resistant. So our experience cannot be extrapolated as the real thing actually.
But sir, selection wise, even private practice में जैसे आपके पास resistant patient comes, in private practice if patient is not responding, they don't come. So
Yes, exactly. दोनों
selection
issues हैं. We have a strong follow, but in private practice this is an issue. If patient is not responding, it won't come again. तो ये है. सर ने
वजह
स्टेटस
सर
के बारे में पूछा था, तो स्टेटस माइग्रेनोसिस इज स्टिल known complication of migraine where a migraine attacks continues beyond 72 hours and it is still very much there, and it is one of the red flags also for the diagnosis where imaging and everything else should be done to rule out the secondary causes of migraine. And it's a challenging situation. Many times we have found the secondary causes, like many of us won't screen pituitary when we order MRI, and will miss macroadenomas. And we have seen macroadenomas being operated and migraine disappears. So this is there.
Any question? Any other question from the forum, from the audience? Query, comment?
We have Dr. B.K. Wajah, sir. Good evening, sir. Welcome on today's webinar. Wajah, sir, I think please unmute yourself. Vinod Tiwari, sir. I think they have joined. Tiwari, sir, good evening.
Good evening, everybody.
Hi, good evening, sir.
Well, basically, I just joined a little late, and
Yes.
and I think I joined just at the time of what he was telling about that monoclonal antibodies, and I'm very sorry for that one. Well, where can we find this monoclonal antibodies? Here in Lucknow or in nearby?
This is
Novartis
marketed
was-
by Novartis.
Okay, 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 okay.
Novartis का आदमी हो, आप उसे कहिए तो वो
अच्छा,
आपको प्रोवाइड करा देगा.
ठीक ठीक, वेरी वेरी थैंक.
हाँ.
ये सिंपल क्वेश्चन
ओवर
था.
द काउंटर नहीं मिलेगी.
अच्छा अच्छा अच्छा.
Yes.
अच्छा, मैं बेसिकली इसके अंदर जो माइग्रेन का जो बेसिकली न्यूरोसर्जन भी ट्रीट करते हैं, तो मेरे पास भी पेशेंट आते ही हैं. तो मैं इसमें एक माइग्रेन डायरी टाइप अपना बना लेता हूँ. दिन भर, पूरे दिन भर को 4 भाग में डिवाइड कर दिया. शाम को उसने पूरा भर के मतलब भरना है इसको, चार्ट को. तो एक 0 to 0 +1 +2 +3 इस तरह करके एक उसको भरने के लिए मैं बोल देता हूँ. 0 में जैसे उसको दर्द बिल्कुल भी ना हो, +1 में दर्द है पर सहन कर पा रहा है, +2 सहन नहीं हो पा रहा, +3 जिसमें साथ में कोई कॉम्प्लिकेशन साथ में हो रहा, नोजिया, वॉमिटिंग, ये सब. तो उससे कुछ आइडिया लग जाता है. वेल, आई डोंट थिंक सो, बट अ लिटिल बिट कि हाँ उसके माइग्रेन के आसपास हम लोग पहुंचते हैं.
नहीं,
सो
वो
दैट्स माय वे ऑफ
डॉक्टर विनय ने
स्टेटिंग.
उसके बारे में बहुत डिटेल से बताया, डायरीज दिखाई भी थी. और डायरी का पर्पस एक तो डॉक्यूमेंटेशन ऑफ फ्रीक्वेंसी ऑफ हेडेक तो है ही, लेकिन हम लोगों के लिए डायरी इज मोस्ट इम्पॉर्टेंट बिकॉज वी वांट टू नो द ट्रिगर्स. तो हमें कॉलम बनवाते हैं उससे कि भी उसको जो भी समझ में आता है, इवन रिमोटली उसे लगता है जैसे कोई उसको लगता है कि बहुत रिलेटेड बात नहीं है, बट उसके दिमाग में है तो लिख ले एंड सी द पैटर्न. बिकॉज प्रोफिलैक्सिस का एक टाइम लिमिट है, कब तक देंगे प्रोफिलैक्सिस का. तो
बिल्कुल सही बात.
लाइफस्टाइल मॉडिफिकेशन जब आपको एडवाइस करना होता है तो आपको पता होना चाहिए कि क्या चीजें उसको अवॉइड करनी है.
क्यों
तो
ट्रीटमेंट
ट्रिगर्स बिकम वेरी इंपॉर्टेंट.
अंदाजा लग जाता है कौन सा ट्रीटमेंट किसके लिए इफेक्टिव हो रहा है,
यस.
और हो जाता है जल्दी.
अच्छा, डायरी बेसिकली बनवा रहा हूँ 2004 से ही, जब पास आउट हुए थे उसके बाद से ही बनवा रहे
ओके.
थे. तो काफी इकट्ठा हो गया, लगभग 2.5-3 हजार के ऊपर तो पेशेंट्स का इकट्ठा हो ही गया है.
तो आप छाप दीजिए सर उसको.
मुझे नहीं मालूम कितना दैट इज, मतलब वेल दैट इज ऑथेंटिक और नॉट
आप
ऑथेंटिक, तो
इंडियन
कैसे
जर्नल
पता
में
चले.
छापिए, मुझे लगता है आपसे ज्यादा डायरी भी किसी न्यूरोलॉजिस्ट ने नहीं बनवाई होगी.
अच्छा,
सच है सर।
तो फिर इसको तो प्रेजेंट ही करने लायक है, इसका मतलब।
आप प्रेजेंट
दैट्स
करिए
गुड।
उसको कि आपने इतने लोगों की डायरी बनाई और ये पैटर्न निकला, वो भी
उसको मैं
बहुत
फोटो
हुआ।
कॉपी कर लेता था, फोटो कॉपी बहुत
हाँ
रखी पड़ी है।
बिल्कुल बिल्कुल, ये अच्छी
हेल्प।
इंफॉर्मेशन।
बहुत कम लोग इतने दिनों तक रखते हैं उसको।
नहीं है
2004
मेरे
इतने
पास,
सालों से रख रहे हैं।
बिल्कुल है। अब तो खैर उसे फोटो खींच के एक उसमें लैपटॉप पे डाल देते हैं, पहले इसकी फोटो कॉपी किया करता था मैं।
अच्छा,
अब इसका ये हुआ, अभी ये हुआ, अभी इस तरह करके। चलिए, वेरी
Good,
वेरी
good,
थैंक्स, थैंक्स फॉर
very good.
दिस वन। थैंक
चलो, anything else from
Any other
any?
question? So I think we should
Yeah,
conclude.
yeah.
So Nanta,
Yes,
wish. Uh,
Thank you, sir, for such an informative talk. And I'm sure most of our doubts and inhibitions regarding migraine treatment have been solved today. So I request Dr. Arvind Kankane, sir, for giving the vote of thanks.
I thank you everyone for joining this session and make this event a great success. I would like to thank Dr. Vinay for speaking such a nice topic on migraine. He has covered almost everything regarding management and treatment. I would like to thank our chairpersons, Dr. Bimal Paliwal sir, Dr. Deepak sir, for giving their valuable input and feedback. I would like to thank Dr. Nanta for moderating this session, and I'm thankful to all of viewers, all of the attendees who joined this session, especially Dr. Vingar sir, Dr. Maurya sir, Dr. Oja sir, Tiwari sir, and everyone else. And lastly, I would like to thank our technical team, Mohit and Harshit, for holding this web platform for us. Thank you,
Thank you,
everyone.
sir.
Thank you for a great presentation.
thank you so much. Thank you, Dr.
Thank you, sir. Thank you.
थैंक यू, थैंक यू।
Session, sir.
जी सर। सर प्रणाम।
Pranam,
Hope
sir.
everything is good.
Everything is good. All
Yeah,
good.
sir.
All well. Thank you. Thank you very much.
Sir, most welcome,
Thank
sir.
you,
Sure,
Nanta.
sure.
Thank you, sir.
जी
Okay.
सर।
Bye
Okay,
bye.
sir. Thank you, sir.
Thank you. Good night, sir.
Good night. Bhai.